Hello and welcome everyone. My name is Alyssa Creamer and I am the Director of Community Services at the Immune Deficiency Foundation, and I would like to welcome you to this session on congenital athymia. So at this time, please join me in welcoming our presenter, Dr. Megan Cooper. Dr. Cooper is an Associate Professor of Pediatrics at Washington University in St. Louis and the Director of the Jeffrey Modell Diagnostic and Research Center for Primary Immunodeficiencies at the St. Louis Children's Hospital. Welcome, Dr. Cooper.
Thank you. Thank you to the IDF for inviting me to speak about this interesting topic. Thank you to the IDF for inviting me to talk and also for selecting this topic on congenital athymia, because I think this is a very important topic as we are beginning to diagnose more of these patients through newborn screening, and we'll talk a little bit about that. So I do have one relevant financial disclosure. In the past, I have received consulting fees from Enzavant. So this is an outline about what we're going to discuss today. So I'm going to talk a little bit about T cell function and development, because this is really fundamentally the problem in patients who have congenital athymia. So we'll talk a little bit about what T cells do, where they come from, how they develop. Then we'll talk a little bit about what is congenital athymia, how do we diagnose congenital athymia, and then what we know about the impact of congenital athymia on the health of patients and their wellness, as well as impact on families. And then finally, we're going to finish up talking about precision medicine in congenital athymia and new approaches that are coming on. So what do T cells do? If you're listening to this, perhaps you are a patient or you have a family member who has congenital athymia, and you've probably heard of T cells, and your doctors have been looking at your T cell counts. So T cells are really a very important immune cell that we have. So they're one of our white blood cells. They have two primary jobs, and really these are the main jobs that our immune system has. The first job is to get rid of what I call invaders. So our T cells need to be able to recognize when an infection is present. If you have a bacterial infection, if you have a viral infection, our T cells need to be able to sense that. And the T cells need to be able to mount an immune response to be able to help the body destroy that. They also need to be able to recognize tumor cells, cancer cells. And so this picture right here is showing a T cell, for example, recognizing a virally infected cell here and killing that cell. Similarly, a T cell is able to recognize a cancer cell and able to kill that cancer cell. T cells also have a unique ability in that they can actually remember their prior activation. So if a T cell finds a pathogen, finds a bacteria, finds a virus, it mounts a good immune response to that. Years later, that T cell can remember that immune response and can act quicker the next time. And so this is part of the basis of vaccination. When you receive a vaccination, you not only have an antibody response, which are little proteins that our B cells make, but you also have a T cell response in many cases. And our T cells are very long-lived and they can remember infections very well. The second main job of our immune system is, while it's doing this, while it's fighting infection and it's fighting cancer cells, it needs to leave our healthy cells alone. And this is really the basis of autoimmunity. So when our T cells are unable to distinguish healthy and unhealthy, so a healthy cell, for example, from a virally infected cell, that can be the basis of autoimmunity. With these two jobs, T cells have a lot of learning to do, essentially, to be able to carry out their duties. So it's important to think about, as you're thinking about, okay, how do the T cells learn to do this? How do T cells develop? To think about, where do our T cells come from? So our T cells actually start in the bone marrow. And so in the bone marrow, we have progenitor cells, and these progenitor cells, or bone marrow cells, can turn into every type of white blood cell that we have, and red blood cell and platelets in our body. Some of these progenitor cells will turn into T cells, and the immature T cells start out in the bone marrow. And then after leaving the bone marrow, they actually have to travel to the thymus, which is where they kind of finish growing up and learn what to do. And so the thymus is often described as a T cell school. So when this very young T cell leaves the bone marrow, it does not know how to recognize infections. It does not know how to recognize cancer. It does not know how to leave us alone. It really has to go to the thymus to acquire all of these abilities. And so the thymus is a very unique place where the T cell can receive signals that it needs to be able to carry out its functions. And then after the thymus, T cells really go all over our body. So you can find T cells in your gastrointestinal tract, you can find T cells in your skin, you can find T cells in your liver. However, one of the main places that they go are to our lymph nodes. And lymph nodes are a key place where T cells go to talk to other immune cells and kind of get instructions and learn what to do, and also tell other immune cells what to do. And so our immune system is a very coordinated response. The immune system really requires kind of all of its parts to be working together and in concert. And it's not just T cells alone, but it's T cells talking to B cells, T cells talking to antigen presenting cells that are very important for our body to have an intact and robust immune response. So because the topic today of congenital athymia, I wanted to talk a little bit more about this T cell school or the thymus, because that is really what is the issue in patients who have congenital athymia. And we'll talk a little bit about why this thymus is so important. So I told you that T cells, immature T cells start out in the bone marrow and then they go to the thymus. I also told you that T cells have the ability to recognize lots of different things. They can recognize infections, they can recognize tumors, and they can recognize a near limitless number of infections. And they can do this because T cells have little receptors on their cell surface. And so here is a T cell, and here's the T cell receptor right here. And these little receptors that T cells have, or I think of them as little like hands that kind of reach out and are trying to test out the environment, they have the ability to recognize just about anything. And they do this because T cells can change their DNA as they're growing up to change that receptor that they have on their cell surface to be able to recognize all the different things they need to. And so we call these little pieces that they recognize, we call them antigens, and they're basically small pieces of protein. For example, if your T cell has seen the flu virus, it's not the entire flu virus that your T cell sees, it's one little part of the flu virus that your T cell sees. So that's the basis of immunization. You can immunize with one small part of the flu virus. The T cells can recognize that small part, and then it can thereby recognize when a cell has been infected by that virus. So because T cells have this ability to change their DNA and to recognize all of these different types of antigens with their receptors, they need to learn the difference between self and non-self. So self means our own proteins. So we don't want a T cell that recognizes, for example, insulin proteins. Or we would not want a T cell that recognizes the normal proteins that are present in your thyroid gland. However, if you do have T cells that recognize these, for example, you may develop type 1 diabetes if you have T cells that are recognizing insulin. You may develop autoimmune thyroid disease, so low thyroid problems, if you have T cells that escape that recognize thyroid proteins. And at the same time as they need to distinguish what is self, so what are the good proteins, they need to know what non-self is, and they need to learn how our immune system will tell them if there's an infection, tell them if there's cancer, so that they can do that. So all of this teaching goes on in the thymus. And this is a very unique environment, and there's really no other environment in the body that provides the exact signals that T cells need to learn self from non-self. So this is really the reason why the thymus is so critical for our T cells to be able to carry out their functions. So what is congenital athymia? So congenital athymia is an ultra rare disorder. The best estimates are there are 20, maybe 30 cases a year in the United States of congenital athymia. And really what congenital athymia means is that it's a failure of the thymus to develop properly. So for some patients, this might mean that they have what might be termed a complete absence of the thymus. So an infant born without a thymus. In some cases, there could be what looks to be a thymus there. So if the physician takes an X-ray or does a CT scan, it looks like there's something there, but really that thymus did not develop properly and it can't support those T cell education functions that need to happen. This is present from birth. And at birth, patients who have congenital athymia will have absent T cells. And so because these patients have absent T cells, we are now in the United States recognizing these patients based on our SCID newborn screen. So SCID, or severe combined immune deficiency, is a type of immune deficiency where patients lack T cells. It can be due to a number of different reasons, but here thinking about congenital athymia, if you don't have a thymus, you can't properly educate your T cells and you don't get any of those, you don't get any T cell development essentially. And so patients with congenital athymia are generally identified on newborn screening, which is going on in all 50 states of the United States. However, while patients are generally born without T cells, as some of you who may be affected by congenital athymia in yourself or your family members may know that after birth, it is actually possible for some very, what we would say, poorly educated T cells to escape. And this is because those very young T cells or T cell precursors are coming out of the bone marrow. So those are still there. The bone marrow works just fine. That development from a stem cell to a precursor T cell is working just fine. However, what happens is that there's no thymus for proper education and proper development of the T cells. However, sometimes there's a few T cells that just go on to develop, but because they haven't gotten the right signals, they don't know how to recognize self and they don't know how to recognize non-self. And so what can happen in these patients is they are susceptible to infection still, even though there are maybe some escaping T cells, because their T cells never learned how to recognize a pathogen, bacteria, virus. They also might suffer from autoimmune disease, or what we might even term a autologous graft versus host like disease, because the T cells don't know how to recognize healthy self cells, and they are kind of indiscriminately attacking. It is unfortunately rare for children to live past the age of 2 or 3 without more definitive therapy to really replace the T cell compartment. So what are the causes of congenital athymia? So one of the most common causes is something known as 22q11.2 deletion syndrome, or DeGeorge syndrome. And in DeGeorge syndrome, there's a very wide spectrum of disease. So some patients with DeGeorge syndrome have complete congenital athymia and they lack T cells. Although definitely the majority of patients with DeGeorge syndrome have a more mild phenotype and they have some mild thymic defects. And so they generally do have T cells. But those patients who completely lack T cells with DeGeorge syndrome will be picked up on newborn screen. Some other things include something called CHARGE syndrome. There's a few other rare genetic disorders that can cause congenital athymia. And then we also recognize that environmental exposures, sometimes during pregnancy, including diabetes and certain medications, can potentially lead to congenital athymia in the infant. So what is the impact of congenital athymia on patients? So this was a recent publication that looked at this, and this publication looked at the medical records of patients with congenital athymia and looked at a couple different things, but I would like to point out in this slide that the study identified that infants with congenital athymia suffer from recurrent and very severe infections. And so this is looking at the medical records of 10 patients with congenital athymia. Remember, this is a very rare disease again, and looking at the occurrence of infections in an average year. And so you can see here the average annual frequency of respiratory infections. So this is lung, respiratory tract, skin infections, gastrointestinal infections, genitourinary, this is generally urinary tract infections, sepsis, and I'd really like to point this out, about 40% of patients with congenital athymia in an average year had an episode of sepsis, which means bacteria in the blood. This is a type of infection that can be very serious and often requires care in an intensive care unit for these patients. And for these patients who had sepsis, the average annual frequency was 3.5 times a year, which is quite significant. Other types of infections they had were systemic viral infections. So this might be a severe infection, for example, with EBV or CMV. They also suffered from sinus and ear infections. And in the same paper, another factor that we had looked at was the inability of T cells to recognize self properly. And so I referred to this before as autologous graft versus host disease. And this is really meaning that the T cells that are escaping, so the infants are born without T cells, but after a time, there are some T cells that are escaping, and those escaping T cells don't know how to properly recognize self, and they can actually attack self. And so in the patients that were surveyed in this report, 70% of those patients with congenital athymia had some type of GVHD-like disease. This was typically skin, and this is not from that paper. This is showing another patient from a different publication who had autologous graft versus host disease, meaning the T cells are attacking the skin here. It affected the lungs of the infants, and so T cells were attacking lungs, and patients had lung disease. The gastrointestinal tract, this can make it hard for children to grow and to be nourished because they don't absorb food well. And lymphadenopathy, meaning very large lymph nodes because of some of the T cell reactions going on in those lymph nodes where T cells are hanging out. Patients with evidence of autologous GVHD are generally frequently hospitalized. In general, patients with congenital athymia had a high rate of hospitalizations, require multiple medications, including medications to help prevent infections, things like immunoglobulin therapy, antibiotics, antivirals. Patients have to undergo a number of different tests and medical procedures as the families work with the physicians to really try to keep these kids healthy. In a separate publication, families of patients with congenital athymia, so caregivers actually were surveyed and asked to talk about what it was that really was presented the most burden to the families caring for these children. And so when families were asked to kind of rank things that caused them stress in their families, the percentage of times that one of these was in the top 3 is shown here. So about 100% of the time, families indicated that isolation and emotional burden were some of the top stressors that they had related to their caring for their child with congenital athymia. Other things that people mentioned were financial hardship, the inability to meet family and friends. And this is really because these children are highly susceptible to infection. And it can be a very isolating, as you see up here, isolating thing. And there's really a very high degree of concern and really just an overwhelming thought among these caregivers that they really are responsible for keeping their child healthy, which obviously, in these families is true. There was a significant burden of medical care. Oftentimes family has had to drive hours to receive the specialty care that they require. Just a general lack of normalcy for the family. So not being able to do other activities that other families are able to do because of the medical needs of the child, and also the real concern and the real challenge that these children are highly susceptible to infection. There's concern for the impact on the patient's development. So is the child meeting all of their milestones? And that's a very big concern. And even impact on siblings' development. So some of this isolation can certainly affect siblings in the family who aren't able to have their friends over. Maybe the siblings aren't even going to school because there's concern. Excuse me. There may be concern about the siblings going to school and bringing infections home. And these are all choices that families have to make with this condition. So I'm going to talk a little bit now about the precision medicine aspect of congenital athymia. And so I mentioned in the beginning that patients can be diagnosed at birth with a newborn screen. And so when a patient is diagnosed with a lack of T cells at birth, one of the things that we as physicians have to look at is this lack of T cells due to a problem with the bone marrow, which is where those very young precursor T cells start out, or is it a problem with the thymus, which is where T cells basically learn to grow up and where T cells finish their development. And so there is actually a need for diagnostic tests to tell the difference between these two. And I just wanted to point out that two groups, one from the NIH, Dr. Notarangelo, and then Dr. Haddad in Canada, have come up with assays that are actually able to test this by taking premature immune cells, premature hematopoietic progenitor cells. So basically the cells that will turn into the naive T cells or young T cells, and taking those cells and trying to, in a tissue culture dish, meaning in their labs, trying to push them into developing into T cells. And so by using this test in the labs, it's possible to determine whether it's actually a thymus problem or whether it's actually a problem with that precursor cell that it's not able to develop into a T cell, and that means it's a bone marrow problem. One of the challenges is that these assays are still experimental, and these are not clinical tests that can just be ordered. And so this often means that these patients, sometimes, unless there's a very clear cause of congenital athymia, such as DeGeorge syndrome, or Charge syndrome, or some of the other precise genetic causes. But for those patients that don't have that precise genetic cause, and we are stuck kind of wondering, is it a bone marrow problem or a thymus problem? We have to think about some of this research-based testing to be able to determine that. So what is the current treatment for congenital athymia? So current treatment is primarily supportive. So the patients receive antimicrobials, so antibiotics, and antibody therapy, immunoglobulin replacement therapy. There are several ongoing efforts to basically help the body reconstitute T cells and to help reconstitute T cells. And I should point out that there are no FDA-approved therapies for congenital athymia. So the first is cultured thymus tissue. So what this is taking thymus tissue from healthy individuals, and this is generally from otherwise healthy infants undergoing cardiac surgery, where the part of the thymus needs to be removed to access the heart to conduct those surgeries. And to take this thymic tissue, and it is cultured and processed and then given to infants who have congenital athymia. This has been going on for over 25 years now, and really has been spearheaded by Dr. Markert at Duke. And she has recently published her 25 years of clinical trial experience, and demonstrates that these children have about a 76% survival rate after 2 years, which is really fantastic for a disorder in which these children are generally not expected to live past the age of 2 or 3. The second effort to provide these children with an adequate T cell population of T cells is bone marrow transplantation. Now, the challenge here is that these kids with congenital athymia do not have a problem with their bone marrow. And really what happens in the context of bone marrow transplant for congenital athymia is that you are giving these kids a new marrow, but you're also giving them mature T cells from a donor. And so basically most of the T cells that these children are going to have are going to be these T cells that they got from a donor. And this unfortunately leads to a little bit lower survival. So it's 41% survival. And there's a very high risk of GVHD. In this case, it's caused by the T cells from the donor attacking the recipient, attacking the patient who received those T cells, because the T cells from the donor didn't grow up in that patient, and they don't know how to recognize the patient as self. And then the third thing I just wanted to mention is that there are some efforts in what we call preclinical, meaning just experiments in the lab that are ongoing by several different groups, where they're trying to actually generate an artificial thymus. So could you take some cells from a patient with congenital athymia and try to generate an artificial thymus and then give that thymus back to the patient? And I think that's a very intriguing possibility and something that we may see in future years. So to summarize, congenital athymia is a rare disorder that causes a lack of proper T cell development because the developing T cells do not have a place to go to after they leave the bone marrow, and they don't have a place to become educated. Patients with congenital athymia suffer from infections. They have autoimmunity because of that autologous GVHD. And there are a lot of challenges in caring for these patients and a lot of stress to the families as well. Congenital athymia can now be diagnosed at birth because we have newborn screening for severe T cell deficiencies. Although I will say sometimes it can be challenging to completely diagnose whether a patient has congenital athymia versus a bone marrow problem. And current treatment is supportive, primarily trying to prevent infections. There are several therapies that have been tried in patients, including cultured thymus tissue, which there is the potential for FDA approval for this cultured thymus tissue, hopefully in the near future for patients. And that's all based on work that Dr. Markert had done at Duke. Some patients have been treated with bone marrow transplantation, in which it's not just giving the marrow, but mature T cells from donors. And while less successful, that has worked for some patients. And I think that there's really the potential to apply precision medicine technology to congenital athymia in the future to better treat this disease. So I'd like to thank you. I'd like to thank our clinical team, and I look forward to any questions.
All right, thank you so much, Dr. Cooper, for providing that amazing presentation on congenital athymia. I just want to say to everyone, you are welcome to ask Dr. Cooper a question that is accessible on the platform. It should be on the right-hand side of your screen that says Q&A. But there is one question that I see at this moment. Somebody is asking, which medication or medications and environmental exposures could lead to a diagnosis of congenital athymia?
Okay, so I think that question is asking about maybe women who are pregnant and their infant may have congenital athymia. So it's a great question. Some of the retinoid therapies have been associated with congenital athymia. Insulin-dependent diabetes has been associated with congenital athymia. I believe some seizure medications have been associated. Now, when I say, I do want to clarify that when I say associated, there is some risk, but by no means do taking these medications or having these conditions mean that your child will have congenital athymia. It is just a risk factor for it, and it's still a very small portion of those pregnancies that the infants would be affected by that. There's really no screening that we can do in utero, meaning an ultrasound can't tell you if your infant has congenital athymia. In general, I would really I would defer to the obstetricians to really guide the patients about what are safe medications to take during pregnancy.
Thank you, Dr. Cooper.
Yeah.
You spoke a little bit during your presentation that many individuals with congenital athymia get picked up through newborn screening for what many hear as severe combined immunodeficiency. Would you say that most children who get diagnosed with congenital athymia come through that newborn screening process, or are others being diagnosed clinically?
I would say that now in the United States, just about 100% of the congenital athymia patients are coming through newborn screening because really these patients lack T cells when they're born, and so they are pretty well picked up on newborn screening. The newborn screening for T cell deficiency is very good. There are always going to be some rare cases that are potentially missed, but I think that it's probably pretty close to 100%.
Another question that's coming in, someone is asking, is there any data on success rates outside of survival? What percentage and in what time frame do patients develop functional T cells?
Sure. So I think maybe the person's referring to Dr. Markert's data, her 25 years of clinical trial experience with cultured thymic tissue. And so in that, what she had presented, it's generally around a year, 12 to 18 months after the thymic tissue implantation that the patients start to develop T cells. Obviously, there are patients who start to develop them a little bit earlier, and even she has described patients who develop them later, but in general, it's about 12 to 18 months. And in terms of other outcomes, I don't have those numbers in front of me, but really the kids who survive after about a year after their thymic tissue implantation, they do very well. So the survival rate that I had shown was for kind of all patients. But if you get past that first year after the thymic tissue implantation, your survival is even better. And in general, with regards to your immune system, those patients aren't getting infections. And their immune phenotype is very good. Now, I think that the other things, so there's other things besides survival you want to think about, right? You want to think about quality of life for the children. And some of those things are influenced by the underlying disorder that leads to their congenital athymia. So some underlying disorders that cause congenital athymia lead to other problems. So some of the children might have heart disease. They might have other abnormalities, even neurologic abnormalities or things like that. So it really, I think, is also influenced by the underlying disease. But in terms of the immune phenotype, the children do very well with regards to infection and the ability to really have a good intact T cell response.
Thank you. Can you talk a little bit about long-term follow-up and what happens in the months and years after treatment? Like, how often should these patients be following up with their provider? Is there anything they should be on the lookout as they age and go into school and high school and off to college and become adults?
Sure. Yeah. So for those children that get the cultured thymic tissue, really the first few years after that procedure, they're followed very closely. So in the beginning, it might even be weekly, and then monthly, and then every 3 months and every 6 months. So you're going to have a very close relationship with your immunologist who's caring for you. As the children get out a couple of years past the thymic tissue implantation and they're able to be fully vaccinated, and Dr. Marker has even recommended, and does with her patients on her clinical trial, lets them have live vaccines. Really, they can do quite well. We care for in our practice a teenager who's I think seen once a year for their congenital athymia. Because they have been treated and have essentially normal T cell function. Whereas if our patients who are younger who have received thymic tissue implantation, we're still watching them pretty closely. But the goal is that kids are going to school, they're doing really kind of everything their peers are able to do. Obviously, you want to watch for infections, and really that's probably most important in the first couple of years. The other thing to consider is autoimmune disease, and that is something that we'll be monitoring for through our exam and through our history and through some basic screening labs that we do.
Thank you. Going back to newborn screening a little bit. So since all states started screening for SCID, of which congenital athymia can get picked up through that process, have you seen or does data show that the prevalence of congenital athymia is different than what was originally maybe thought in the population, whether that's just in the US or worldwide? Can you speak to that?
So I am not aware if there's any data that's showing this or not, and I apologize that there definitely could be, I'm just not aware of it. Anecdotally, certainly in our practice, we have observed that. We have observed, children who their underlying genetic conditions weren't necessarily previously appreciated to have such a high rate of have congenital athymia as a significant complication. So for example, infants with CHARGE syndrome, even 10 years ago, were not, part of the screening, it was not thought as much to think about congenital athymia in those patients. but certainly with newborn screening, more and more of those patients have been identified. And so I think that certainly we are identifying more patients now.
Okay, so somebody is asking, are there any studies regarding COVID-19 and post-thymus transplantation patients? Are these individuals at higher risk than the rest of the population, especially those who have lower T cell levels?
Yeah, and that is a fantastic question. We don't have data on that yet. I can say that among immunologists, we've shared a couple of our patients who have been exposed to COVID-19 or had COVID-19 infections. And I am not aware of any congenital athymia patient who has had a severe infection. But I think the numbers are just too low at this point to say. But certainly for congenital athymia patients after their thymic tissue implantation, do want to be very cautious with any viral exposure for the first, really for the first couple of years, but definitely in that first 12 to 18 months.
Awesome. Thank you, Dr. Cooper. I'm glad whoever submitted that one was able to sneak it right in before I signed off. All right, let's see. Anything else? Going once, going twice. All right, I think we can call it. All right, thank you again, Dr. Cooper.